Hello, everyone. Welcome to the Bridging Communities with Systems Change, Advancing Health Equity and Promising Practices conference web series brought to you by the Appeal team. This is session 2 of the Addressing Equity Strategies and Development of Promising Practices among Asian Americans for Health Departments and Communities. And it's really focused on Asian Americans, intersectionality, and bringing equity for all. So this is the September 21st, 11 a.m. Pacific time, 2 p.m. Eastern Standard Time session. I am Program Coordinator Michelle Ju of the Aspire team with the Appeal network. Okay, next slide. So a little bit about Appeal. Appeal is a national nonprofit working to advance health equity and social justice. To eliminate commercial tobacco and cancer health-related disparities in Asian American, Native Hawaiian, and Pacific Islander communities. And we've been doing this since 1994. I work on the Aspire team, which is one of 8 national networks funded by the Centers for Disease Control and Prevention. And we've brought you the current web session today. The Aspire team provides key technical assistance and training to communities and state programs. Next slide. Here's just a quick representation of the communities that we represent. It's not all inclusive, but it's just some of the faces that we see every day. Next slide. A quick agenda, we'll do some housekeeping. I'll introduce our Executive Director, Rod, and our special guest from the CDC. Presentation by Scarlett Lynn Gomez, a presentation by Elaine Ishihara, and a presentation by Nora Lynn De La Pina. It's a facilitated dialogue and discussion will follow with a Q&A and closing statements. Next slide. A little bit for housekeeping. This is a webinar format Zoom call. Your video and mic is off throughout the entire webinar. Please ask your questions by clicking through the Q&A icon or as listed in the chat. And if you have any other comments, please put those in the chat box as well. Technical assistance is brought to you today by Deshaun Bailey and myself. And the webinar will be recorded and posted on the designated program websites for you to view at a later time. Thank you, and excited for all of this to happen. Next slide. So here are our 3 speakers, Elaine, Nora Lynn, and Scarlett. Next slide. And we'll have our Executive Director, Rod, bring you an introduction before Christopher Benjamin speaks to you as well. Pastor Rod.
Thank you, Michelle, and welcome everybody to this really important webinar focused on Asian American communities. Again, my name is Rod Liu. I'm the Executive Director of Appeal, Asian Pacific Partners for Empowerment, Advocacy, and Leadership. We are one of the 8 funded national networks by CDC. We have had a partnership with CDC for nearly 28 years that we've been in existence, and really appreciate the support that CDC has provided. And it's a great honor for me to introduce Chris Benjamin, who's going to be doing the welcome from CDC. Chris is the Deputy Director of the Program Services Branch at the Office on Smoking and Health at the Centers for Disease Prevention and Control. Chris has had probably nearly 30 years, more than 30 years of experience working at CDC. Started off working in kind of the policy arena and kind of developing program expertise to his current role right now at the Office on Smoking and Health. I have known Chris for a long time and have come to really appreciate not only his expertise around commercial tobacco control, but his community sensitivities. We were talking earlier at the beginning of this call, and he said something to me which really resonated very powerfully, and it's going to be a theme of our discussion today. And that is that we need to meet people where they are. And I think that's exactly true when it comes to talking about our communities and our marginalized communities. So please help me welcome Chris Benjamin.
Thank you, Rod. Rod and I go way back, and I don't have a lot of time for my welcome, but I do want you all to know that everything that I say comes from my heart and my mind, and it's a pleasure to be here with you all today. So on behalf of the Office on Smoking and Health, it is my pleasure to welcome all of you to today's webinar hosted by Appeal. CDC OSH supports efforts to identify and document how best to work with distinct racial groups like Asian Americans. As part of OSHA's Health Equity Plan, the 8 national networks, including Appeal's Aspire Network, are compiling guidance along with a compendium of ideas to plan for culturally relevant ways to work with multiple communities that experience tobacco-related disparities and inequities. Research has shown that there can be substantial differences in tobacco-related behaviors within population groups. Data, for example, from the National Survey on Drug Use and Health showed that 10.9% of Asian American persons reported current tobacco product use as the lowest among racial ethnic groups during those years. However, disaggregated data during those years showed that prevalence of tobacco use differed significantly among different Asian American populations. These findings underscore the need to measure differences within population groups as much as possible. This may be particularly relevant for states and communities that have a large proportion of diverse population groups. Tobacco control programs may need to oversample for some population groups to collect, analyze, and report on disaggregated population group data. OSH also encourages states and organizations to use the Asian Smokers Quit line that serve Chinese, Vietnamese, and Korean speakers in their language. We thank you for attending today's webinar. We encourage you to continue to engage with Appeal to better understand and work with Asian Americans. Again, thank you, Rod, for convening us today. We appreciate the opportunity to learn, grow, and further our commitment to health equity for everyone. Rod, back to you.
Thank you, Chris, for that warm and wonderful welcome, and really, again, the partnership with CDC over the years. I also do want to acknowledge that we work with both the Office on Smoking and Health as well as the Division of Cancer, and those are the focus areas that we have through our national network and that we are going to be discussing today. I wanted to share a few slides before I turn it over to our illustrious panel, and that is to provide a little bit more context to what the topic of bridging communities with systems change actually means. First, just want to acknowledge our great team at Appeal and at Aspire, also our Aspire partners and our Aspire network all across the United States, but also with Pacific Island jurisdictions. Health equity has been talked about in many different ways. Here's a couple of definitions that we like to share, both which talk about the fairness and fair and just opportunity that health equity really indicates. Paula Braidman from UC San Francisco probably has the most elaborate definition of health equity, which she actually tested part by part. So it's very comprehensive. But one thing that I think is important is really not only the focus on fairness, but the need to really explicitly state that systems change is one of those barriers. And systems change includes institutional racism, homophobia, and transphobia. But what is systems change? This is from Catalyst 2030 website, where they describe systems change generally understood to require adjustments or transformations in the policy practices, power dynamics, social norms, or mindsets that underlie the societal issue at stake. What you see here is a picture of an iceberg, so that there are varying levels of change from incremental to structural, and the most deep-seated, which is the transformational change. Where does change need to happen? In our public health world, I would kind of describe several different arenas where we should be working. At institutions where commercial tobacco control and cancer control should be addressed. For example, at local, state, health departments, federal health agencies, research institutions, and mainstream public health organizations. But also it should take place at institutions where there are root causes of health inequities, sometimes described as social determinants of health. And this can be healthcare institutions. This can be institutions that deal with housing. It can be institutions that deal with criminal justice, our prison system. But beyond that is really the impact that policies can play. And certainly in commercial tobacco control, policy change has been a very important part of all the work that we've been doing over the past several decades. But it's really important to underscore that these policies must be assessed and developed as equity-centered policies. But there are also policies that impact systems change, such as institutional racism and homophobia. So those are some of the things that I would describe as where the systems change should take place. One piece I wanted to mention briefly is the difference between transformational and transformative change. You saw in that definition from Catalyst 2030, they used the word transformational, which basically just means relating to a major change. I would offer that what we're really trying to move towards is transformative change, which is having the power to transform. And this to me really means that communities will be given and empowered the ability to make decisions on how their health outcomes and outcomes will appear for their involvement in any of this work. And I think it relates also to the kind of leadership that's being done, that it isn't just enough to have transformational or transactional leadership, but that what we're really looking for is transformative leadership. So with those new points, I just wanted to offer this as a new proposed definition of systems or systemic change, which really strives for transformative change in policy practices, power dynamics, and social norms that underlie commercial tobacco, cancer, and societal inequities. The focus is particularly on one, positive change with all institutions prone to inequities, perhaps due to structural racism, homophobia, and two, through equity-centered policies at the local, state, and national level. This is perhaps why we developed this four-pronged policy change model to identify that policy change should happen not just at the legislative level, but at other levels. So you'll see the second tier up from the bottom is really about that institutional change. How can we address systems change? I think there are really kind of 6 areas that we can focus on, and hopefully we'll talk about this in some of the Q&A later. One is funding mechanisms. Second is, as Chris mentioned, data disaggregation, what we would call data equity. Third is equity-centered leadership, that those who are leading these agencies or departments have a focus on equity-centered policies, authentic and trusting partnerships with communities, which comes back to, again, what Chris was saying around meet people where they are. And then perhaps most importantly, accountability, which can be looked at in terms of measures of accountability, but also mechanisms for that to actually happen. We have worked with an equity collaborative in California called ADEPT to come up with what we think are health equity principles for all populations. And these are something that Michelle will share in the chat, particularly wanting to highlight that the health equity goals are really centered on institutional or systems change. At Appeal, we've created a policy platform. I'm not going to go through all of these, but I'm going to highlight a couple of them. Again, the importance of data disaggregation by Asian American subgroups. We know that when you look at studies that disaggregate, particularly around commercial tobacco use, that there are some groups, particularly Southeast Asian groups and among men, where there are higher rates of smoking. And that's really important for us to be able to kind of consider that in terms of the programming and policy that we do. In addition, we should be ensuring that there are community-friendly funding mechanisms so that all communities and all community-based organizations have equal access to applying for those resources. You will notice that we are primarily focusing today on Asian Americans. Yesterday, we had a webinar on Native Hawaiians and Pacific Islanders, and that is intentional, recognizing that NHPIs are a separate racial group. So we are going to be focusing today just on Asian Americans. And then the health equity recommendations, which are things that include mandating health equity plans, again, focused on a systems change approach, and the inclusion of equity-centered policies. One last comment I want to make, because there may be issues around social determinants of health that come up in the presentations and discussion, is that there's this book that came out by Daniel Dawes called The Political Determinants of Health, really looking at the fact that we not only need to talk about social determinants of health, but really that there are disparities in access to policy and policy making, so that we indeed need to have a focus on political determinants of health. I just mentioned this also to let you know that if you happen to be going to the American Public Health Association conference this year in Boston, we are going to have a special panel just on political determinants of health. It's going to happen on Tuesday, November 8th at 8:30 in the morning. So at this point in time, I want to introduce our excellent panel that will be joining us today and speaking. And I'm going to introduce them all and then turn it over to them to do their presentations. First off is going to be Dr. Scarlett Lynn Gomez, who is the professor in the Department of Epidemiology and Biostatistics and a member of the Helen Diller Family Comprehensive Cancer Center at the University of California, San Francisco, where she is also the co-leader of the Cancer Control Program and a member of the Prostate Cancer Program Leadership Committee. She is director of the Greater Bay Area Cancer Registry and the California Cancer Registry, and her research focuses primarily on cancer health disparities and inequities that aims to understand the multi-level drivers of those disparities. Next, our speaker will be Elaine Shoji Ishihara, who is the executive director of the Asian Pacific Islander Coalition Advocating Together for Health, or APICAT. And she has over 40 years of community organizing and nonprofit experience. She values her family, mentors, and cross-cultural partnerships, allowing her to fulfill her passion and commitment to social and health justice and to the communities that are most impacted. Elaine, as I mentioned, is the executive director, which she helped organize APICAT in 1997 to address commercial tobacco control and health equity in the diverse Asian American, Native Hawaiian, and Pacific Islander community in Washington State. And last but not least is Norlin de la Pena, or Nori for short, who is the Commercial Tobacco Cessation Manager at Public Health Seattle in King County's Cannabis, Tobacco, and Vapor Prevention Program. She provides evidence-based tobacco intervention trainings, technical assistance, and resources to organizations who serve people disproportionately affected by tobacco use. And included in this is behavioral health treatment, community clinics, and community-based organizations. She is a Mayo Clinic certified tobacco treatment specialist and a certified health education specialist, and is passionate about providing service and education to increase access to cessation. So please join me in welcoming our panel. I'm going to turn it over now to Scarlett to start us off.
Great. Thank you so much, Rod. And it's such a pleasure to be here as part of this, as you called it, illustrious panel to talk about this important topic. So in my quick 5 minutes, I really wanted to sort of center us on this graphic here, which I particularly like because it really illustrates nicely this continuum of influences on health outcomes. If you focus on the backdrop here, we see mountains, and water that flows from the mountains, the stream that goes down downstream. What we have traditionally focused on, as Rod mentioned, I am a researcher, I'm a professor in epidemiology, and so I'm going to be wearing that hat with the perspective that I'm speaking with here. The research that we've been conducting as a community has traditionally focused on these downstream factors. What are the factors and differences and equities and disparities in terms of behaviors as they relate to health outcomes? What we've started to really appreciate, especially over the past couple of years, is the importance of the social determinants of health, the living conditions in which people are born, grow, work, live, and age. What we need to be moving towards are the importance of the structural determinants of health. This is similar to the political determinants of health that Rod alluded to. These are the wider set of forces and systems shaping the conditions of daily life. This is where we really need to start to move. These are the isms, the social inequities, classism, racism, immigration status, gender, sexual orientation, the factors, racism and homophobia that Rod spoke about, and that shape the equitable distributions of resources within our institutions. So this means that to achieve health equity research, as researchers, we need to start to address the structural determinants of health. And how do we do that? Well, considerations are in bridging communities with those who are doing this research, those who are funding this research, health departments, funders, researchers towards systems change. And I posit that there are certain steps, high-level steps that we may be able to take to start to get there. Firstly, we need to recognize and acknowledge that disparities arise from these fundamental upstream causes. This means that we need to invest in research and interventions on studying and addressing these structural and institutional factors. Rod asked us to give some positive examples where we've seen this play out. And I think one positive example of anything, a silver lining perhaps that came out of the COVID pandemic, is indeed the recognition, at least from the health research community, on the importance of recognizing and intervening upon structural and institutional factors. We need to recognize that there are unique multi-level and intersectional impacts that are faced by communities. And I think importantly, researchers and those that we partner with need to be attuned to the life experiences that are faced by our communities and to incorporate these life experiences into our research studies. We talk about data equity. There are certainly data, I believe that we could really go a long way by requiring data collection, and data collection specifically as granular as possible, and also to include the social and structural determinants of health. One positive example, I think, is the California Health Interview Survey, which is administered by the Health Policy Group at UCLA, which has been for years collecting data on small populations, oversampling small populations, ensuring that their survey approaches are accessible to those small populations, and in turn reporting data for small populations within California. And I think that there's research equity in terms of who is available, how accessible is research funding to everybody, particularly those most in need. We need to really think about how we can remove administrative and legal barriers to community engagement and research. This includes the whole spectrum from applying to grants, doing IRBs, doing data sharing and DUAs, thinking about the research grant life cycle and the discontinuity of funding, et cetera, that comes from this. And that was all that I had. I look forward to further discussion.
Thank you. So, good afternoon, everybody. So I'm going to be coming in from a very community-based level, and APICAT, we have over 25 partners representing the Chinese, Korean, Vietnamese, Cambodian, Lao, Khmer, Samoan, Tongan, and Filipino Khmer communities, representing and involved with social and health services, faith-based organizations, environmental justice, educational service districts, health departments, and intergenerational. I mean, we've really always focused on working together with both adults and youth. And I feel like, what's been transformative for us in doing this work is really the appeal model. And that's Rod had described, but it really includes equity that's centered in the community in doing change. And so we look at adult and youth leadership development, education, data collection, and policy change. Next slide, please. And, we couldn't have done this work or we wouldn't. So basically, we have been doing initially organized to address commercial tobacco control in the Asian American, Native Hawaiian, and Pacific Islander communities. And from the very beginning, we've had a relationship with the Washington State Department of Health and also Public Health, Seattle King County. Both were really instrumental in working with us. I feel like the most important issues or the most highlights was really about how the Washington Department of Health, particularly because they received a grant from CDC to ensure that they were including cross-cultural or diverse communities at the table when Washington State developed the Tobacco Prevention and Control Plan. And so from the very beginning, DOH convened a cross-cultural work group. And I will say that the important thing was really about the community engagement, how we were able to develop a working relationship, and the investment of adequate resources. So APICAT has had a contract with the State Department of Health since 2002. First to do commercial tobacco, adding on vaping, and most recently, cannabis prevention. Along with that, we've always had a really great working relationship with Seattle King County, Public Health Seattle King County. And they reached out to us from the very beginning when we started organizing our coalition. And were very supportive. The staff at the time was really supportive in helping us organize and also getting some resources to assist us in doing an assessment in our community around tobacco. And then introduced us to Rod. So I will say that the appeal model really has been transformative in helping us center our work in the community. And with Seattle King County Public Health, we co-hosted in 1998 the first cross-cultural tobacco forum. So, and along with all of this, it's really about the relationship building and the investment of resources, allowing our communities to lead the work. And so I feel like, our coalition continues. We have had members on our coalition for over 15 years. And it is really about addressing the social determinants of health and ensuring, moving towards really having a healthy community. And then the last slide, that being said, we continue to struggle, I think, with the Asian American community because of data equity. The inequities around not having disaggregated data does not show really what's going on in our communities, not just with smoking, but other health-related issues. COVID is a really good example of that. We have evolved. We do a lot of policy change, just like everything that Rod talked about is how we do our work. And And so it goes along with dismantling the systemic racism and making changes in order for us to really move towards equity. Thank you.
Good morning or good afternoon, everyone, depending on where you are. I'm going to be speaking on more of a higher level coming from the health department. Many of you may have also declared racism as a public health issue. I'm going to talk a little bit about our experience and how we've supported community. This slide here, we have to listen to the community. We have to absorb the values that they want us to have. This I took directly from our webpage. I believe it was under the Equity and Social Justice page. I want to emphasize that we have to absorb the values that they need us to have, like our community needs us. We need to lift up their voices, listen to what their needs are. You're going to hear me talk a little bit about them leading the way in this work and us just providing the technical assistance and facilitation and the connecting the dots to other resources. But really focused on the communities that are underserved, under resources, those who have limited access to healthcare, and et cetera. And next slide, racism as a public health crisis. As I mentioned, many of you may have also declared racism as a public health crisis in your organization, your local health jurisdiction. Our King County Executive, Dow Constantine, declared this emergency or crisis on June 11th, 2020. People were going through some really hard times, as you can remember, and I don't want to bring up, trauma or re-trigger. But this point in time was really historical. It has changed the conversations that we're having at work, at the community tables. We have had conversations around, allowing staff to use their paid time to have spaces to talk about equity and how to engage with one another, how to engage with community. Discussions really around doing work differently. We really acknowledge the fact that we need to do things differently and really dismantle the microaggressions, and the other issues that were going on that were really affecting our communities. Really working even down to grants and contracting. How can we do that differently? And also when it comes to the hiring process, how can we be more inclusive and how can we make it easier for communities to apply for jobs? We're always hearing that the community wants to hear from people that look like them, that have that similar experience, that can relate to the experiences that they have lived. Next slide. I'm going to spend a little bit of time on this slide. Things that we have done to promote systems change in our working with community-based organization is really around educating them. Coming in, just like hard-handedly is not going to work. Talking about what we want to do at the health department or as government, what we think they need, that doesn't work. We found that educating them on what the issues were, how it was affecting the community, the disparities that were involved, how the tobacco industry hones in on certain populations. These are the things that really, I would say, perk up their ears and open up for conversation. And then, when we talk about systems and policy change, not just bringing that up as this is what needs to be done, this is the most effective way to do things, but also having some kind of resource for them. We don't want to just say, we're banning this, we're banning that, and not giving them, for instance, a cessation resource. So really educating and providing the support and resources around that. And I mentioned us providing, playing a role in providing technical assistance and being really the connector in the work we do. As far as serving and supporting Asian American communities, We really tried to involve ourselves and plug ourselves into spaces where the communities are, whether that's in the community or, a lot of our work is done online now. So really being at the tables where these folks are and where the community is, and listening to what their needs are, from serving elderly to young adults to, youth. We're doing a lot of youth focused work now, and engaging a variety of different sectors, whether that's community clinics or the school system, faith-based organizations, et cetera. And really wanting to know what they value, what they care about. And this work really does take time. Our breast, cervical cancer, and colon health program, and our other programs in the health department, we're just trying to plug in and integrate what work they're already doing so that we can bring in the education and prevention on tobacco and vaping and cannabis. And also, making sure that the language is there. I'll go ahead and go to the next slide. Some things that we've done around COVID, it really has highlighted some of the really huge gaps that exist and the barriers. And again, really making sure that we have language access and reaching communities where they are and where they live, where they work. Behavioral and mental health support has been, a critical issue and is very well associated with tobacco and nicotine dependence. Trying to engage folks in, not bringing up necessarily a tobacco program to your community, but really how to integrate what's already existing in their work. And of course, the value of peer-to-peer. Next. More on the COVID response, providing faith-based help and offering spaces for Let's Talk events so that we have a place where people can express themselves, and really integrating the value of promoting mental and behavioral health and the link to substances. And next slide. We'll have more time for discussion at the end, I believe. Workforce, increasing representation. These are some of the other systems, things that we're looking at. Compensating, making sure people are fairly compensated for the work that they're doing in the community, and integrating, like I said, the tobacco work and into other health programming. Next slide. Efforts from within is continued here. Building capacity for community health navigators and community health workers using that model, community messengers. Next slide. And we've heard time and time again about data collection, the need to disaggregate the data and really break down the different groups that exist within the larger group. Thank you.
Thank you, Nori, Elaine, and Scarlett, for those wonderful presentations. I think it really set the context for our dialogue that we're hoping to have. For those of you who would like to ask questions, please submit your questions to the Q&A box at the bottom of the Zoom. We're going to kind of start off with some of the questions that we have prepared. And we are going to be talking about systems change, but I want to go back to talking about the Asian American community first, because I think it is important to get a little bit more context for institutions that may not have had much experience working with Asian American communities. And I want to ask our three panelists if you could turn your video on, please. And I'm going to ask you to respond in about 30 seconds. So I know that learning about the Asian American community can be a lifetime, but I'm going to ask you to kind of pick one or two things that you think institutions, public health institutions, should know about the Asian American community as it relates to commercial tobacco or cancer, or just the community in general. Scarlett, would you like to start?
I guess maybe in 30 seconds, I would choose to focus on the heterogeneity within our communities. I read a really interesting article last night that talked about the history of how these categories came into play and the political agenda that drove the categorization of Asian Americans, Native Hawaiian, Pacific Islanders, which really has nothing to do with any sort of shared experiences or similarities in terms of ancestry. We are a diverse group that come from more than 50 different origins, 100 different languages. And I think that to the extent that we can, data disaggregation to really illuminate where the disparities are, where we do need to focus our limited resources is so important, as our other two panelists have alluded to.
Thank you, Scarlett. Elaine, would you like to go next, please?
So I would just say that, you know, I continue to learn all the time. It's really, I think, the approach on how they educate and share information in their communities could differ. And it is everything from technology, generational, how they came to this country, or if they are from here, like, you know, I'm third generation, but there's still a lot of immigrant and refugees, and just how communities approach educating and distributing information, I would say, in their respective communities.
Thank you, Elaine. Nori?
We oftentimes hear the phrase one size fits all. One size does not fit all, obviously. We really need to take time to build these relationships and build the trust. And I know that, you know, timelines aside, I know that oftentimes we're up against timelines and deadlines, and we want to push the community to do it more or do it faster. And you know, from experience, we know that doesn't work. So really just taking the time that is needed.
Thank you, Nori. I also wanted to kind of point to something that you mentioned, Nori, in your presentation, which is this environment of anti-Asian hate and anti-Asian violence. It's no small thing that we've been experiencing for a long time, but it's become particularly pronounced in this COVID era. Can somebody respond to how has that impacted communities in terms of the work that we want to do in public health? And what are the things that, you know, public health institutions should know about kind of dealing with that piece of it? Who would like to respond?
So I would like to respond. You know, the thing is, and it's like we put out so much information, and but sometimes we just need to ask people and not assume that what they need. And it depends also on the generation and who community leaders are. So when it comes to the racism, you know, and anti-Asian sentiment, it's historical. And maybe part of it is that because we are continue to be dismissed or overlooked because we still come up as the model minority, it's even much more of a challenge in being able to address it because it is not new. And it's really about not having the answers or even thinking about that, but being able to go to the community and just ask them what their needs are. And even for us, you know, I have to be mindful of that because we just want to be so helpful sometimes and try to fix it, but it's not that. It's really about asking people what their needs are.
Yeah, the great Elaine. Any other responses on that one?
I would just add, Rod, in a sort of direct response to your question, is that we've seen particularly elderly Asian Americans in the Bay Area that the fear is real, and people are, we actually were conducting a patient navigation study at around this time, and a major sort of barrier was that folks were not wanting to leave their house to go see the doctor, to their doctor's appointments, to engage in cancer care. And so navigation actually at the time was especially important in terms of just having a sort of partner to accompany patients to their appointments, to help them access the resources and the social needs their social needs. But another positive aspect I think we've seen out of it is communities coming together to try to provide that social support and that feeling of a safety net, if you will, during this time. And I would say from a research standpoint, I think that Elaine's absolutely right, that racism that our community faces, this is not new. It's certainly become more amplified, but I think it has become more in the public sort of space. And from a research standpoint, I think that there is greater recognition that racism and discrimination is in fact a real thing among Asian American communities. So I'm hoping we'll see more funding and investments to studying these phenomenon.
And we really don't know quite yet whether or not this increased racism will impact behaviors like smoking, and whether there's some direct connection. I think we've kind of seen some connection between racism and other kinds of behavior, but this is something that I think we still kind of need to learn more about, but it's a very real thing. I want to keep going on. I know that there is a question in the chat, and this one is for Nori. And let me just preface by saying you all have talked about the importance of starting from where communities are and building relationships. And so this is a question that says, does Seattle-King County have a guide for how to compensate community members? This is especially important for state and local departments of health where there may be bureaucratic challenges. The Colorado Commercial Tobacco Program created one, but it would be helpful to see one from a local health department. Nora, you want to respond?
Sure. We don't necessarily have a guide on how to compensate. You know, as COVID was happening, we were kind of building the ship as we were in it. And so we just really saw the importance of providing a fair and equitable way to do this work. And so we would just bring it out of the funds. Like, for instance, the Best Starts for Kids initiative, we were able to compensate some of our BIPOC providers to assist with some of the emotional distress that was going on and seeing individuals for free. Yet we wanted to, they were, volunteers, but we wanted to make sure that they were compensated fairly. So we ended up just paying out of an account, out of a budget, providing a stipend for them.
So I mean, this is just one
info, Laura.
Okay, thank you, Nori. So this is just one example of kind of building a authentic relationship. So I want to ask you, Elaine, authentic relationships take time, and there are a lot of challenges in that. What are some of the things briefly that you would say helps to kind of nurture an authentic, trusting relationship between communities and public health institutions?
So I would say that at least for public health institutions, they attend our meetings. Not so much the state, but the counties and primarily like Seattle-King County. Nori comes to our coalition meetings. There are others within different divisions that we've met that doing other health related work, and they will come to our meetings and actually get connected with our coalition partners. And just to add on to what Scarlett was saying, during this period of time, I think there's been a increased investment like in community health workers for specific communities. And that has been helpful. So that the ability to be able to introduce people to key community leaders so that they can develop their relationships with them.
So this is certainly the beginning steps of kind of addressing what you would describe, Scarlett, as structural determinants of health, which are kind of deep seated. It seems overwhelming, right, to try to address institutional inequities like that. What message would you give to public health institutions in general about kind of where to start? And then the second part of it, if you can respond to specifically talking to research institutions, what would you say?
It is really challenging, and sometimes when I've spoken about this from a research context, I've actually gotten comments from researchers about, well, what's the point? What can we as researchers do? Let's just stay in our comfort zone and study the behaviors disease link. But I think that hopefully, if there's anything that the pandemic has shown to us, is that these factors are important, these upstream factors, and that they do need to be addressed if we really hope to make any changes on the downstream. So I guess my message would be to not give up, but I think that there still needs to be a lot of understanding from the researcher community of what these structural determinants are and how to actually operationalize them and study them. And in fact, there's NIH is hosting a workshop next week for researchers from the basic sciences, the clinical sciences, to social and behavioral sciences on how to best do this research. So I think we, as much as anyone, need that practical guidance of how to go along. And I think in addition to that, how to partner with communities and work hand in hand so that we are hearing the community voices and understanding how do we translate that into the research that we do.
Yeah, so continuing on from what you just mentioned, Scarlett, Nora, you started from a community perspective and then went to a health department, which I think is the best of both worlds because you can provide a lens that kind of sees both directions. What would you say to public health institutions, other health departments, about a couple of things? One is why they should be doing this, and secondly, what should communities provide to health departments to kind of better provide ammunition for health departments to kind of make those changes? We heard yesterday on our panel with the Pacific Islanders that two panelists politely said, you know, we need to demand, we're demanding. What do you think about that? How should communities approach, and how can they support you on the inside in a health department to create that change?
Let's see, what should communities provide? I think, again, being at the table, if you have a champion, reach out to the champion, make those networks happen, and really make it known what is needed in the community and voice that. And, you know, we know that data is key in getting, you know, action. And so if they can provide that, just testimonials help a lot as well. And in hearing the community what they need, it's important for us on our side to really deliver and follow up what we say that we're going to do, and be at the health fairs, you know, be at their events, promoting their resources. I think a combination of that is really critical in doing this work, and what we should be doing at the health department at the local level. And on the flip side, where communities need to just keep on trying and being persistent in what you need, and really looking for the champions. And, you know, we're always looking for champions at community-based organizations and in community. I think it's important for communities to also reach out to champions at their locals.
Yeah, and perhaps with these champions, when they're voicing concerns for the communities that may be seen as demands, it's really because they are passionate about the impact of these issues on our communities.
Yes,
so thank you
and
for
trying
that.
different angles too. If one way is not working, if you're not getting an email back or phone call back, maybe knock on a door. You know, you don't want to show up and surprise people like that, but oftentimes when we're not able to get emails across, or we can't, you know, we don't hear back, picking up a phone is is a huge connector, and it really, you know, it tends to be that one last step, one last resort to get some conversations going.
Yeah, wonderful. So we're nearing the end of this webinar. Unfortunately, we just have a couple more minutes. So I want to ask each of the panelists to respond in a minute or less of what would be a wish for the next 5 years of something that would impact systems change in a transformative way that could benefit the Asian American community. Scarlett, you want to start?
You had to call on me first, Rod. I guess I would go back to data equity. I think that that is such a fundamental, foundational thing that we need. I think we've seen this with the push to disaggregate NHPIs from AA data and how far we've come with that. If we can keep doing more, you know, to the then I really think that that's where we should be pushing. I feel that I have to speak from epidemiology. Wearing my epidemiologist hat, is that we have been limited by working within the tools that are available to us in our toolbox, and we've become really complacent with, well, the numbers aren't big enough. If we can't reach, you know, statistical stability, then we're going to have to aggregate or leave those populations out of the denominator. Well, that's the tools we have available in our toolbox, and we need to do better. And so I would push upon health departments, those who are collecting and reporting the data, to work together with the statisticians and the epidemiologists to develop better tools in our toolbox. Just because we don't have the tools doesn't mean that the communities become invisible.
Great. So going back to the whole data equity and working with epidemiologists. Elaine, you want to go next?
So I agree with Scarlett. This is something that I've been raising my hand since the very beginning. And it's not just, it's the investment. I'm sorry, there's a, but it's the investment and the instruments that are used to collect the data that is not disaggregated. And I feel like because not only do we need to continue to advocate for our communities, but because of the lack of data, it makes it even that much more difficult or challenging.
Thank you, Elaine. And Nori, you want to cap it off?
I have many wishes. I'll go with this one. My wish is to increase representation and invest in and support young people to seek careers in behavioral health, mental health, education, primary care, law enforcement, just so providing some kind of funding, allocation, scholarship, and encouragement for people of color, especially Asian Americans, to seek these careers.
Yeah, excellent points around involving young folks. Okay, so at this time, I'd just like to thank our wonderful panelists. You can easily see that each of them are great resources. We've had a short time today, but I hope that you will connect up with them and connect up with your health department, or if you're a health department, connect up with your communities, your Asian American communities. Michelle, can I get the last couple of slides to share, please? So I wanted to share just a couple of final slides, things that Appeal as a national network can provide in terms of technical assistance and training. On the left side are some of the things that we've provided to our diverse communities. And then on the right side is technical assistance and training that we've provided to state and local health departments. Next, please. Two pieces that I want to kind of uplift as we talk about promising practice and what works for our communities is that in 2013, we came up with this supplemental journal specifically on promising practices on tobacco control for Asian Americans, Native Hawaiians, Pacific Islanders. We're about to launch a new supplemental issue that hopefully will come out in 2023. But you can kind of see that these are some of the resources that have been already published. The second thing that is soon to come is our promising practices repository. This is where we will identify models and toolkits and projects and policy initiatives that have worked, and they will be posted, on our website. Next, please. Just want to say thank you on behalf of the Appeal team and the Aspire Network for your participation. Thank you all. If you need to reach us, here's contact information. Special appreciation to Scarlett, Nori, and Elaine for their wonderful presentations and for all the work they do for our communities, and to Chris Benjamin for providing the welcome. And thank you all for joining us. And we hope to meet up later on so that we can continue this work to improve health and health equity for all of our communities. Thank you very much, everybody.